Hello, my name's Ivan Bristow. I'm a podiatrist in the New Forest, and I'm very pleased on behalf of Medifoot CPD School to be presenting this update on onychomycosis. So let's start by saying what a big problem onychomycosis and fungal foot infections and generally fungal skin infections are in the world today. Now, many people don't realize that dermatophytes, which are the leading cause of fungal skin infection, group of fungus that have adapted to living on the skin, dermatophytosis, as it's known as, is the third most common disease in the world today. So it is incredibly common. You're going to see it in clinic a lot. And it's estimated around 25% of the global population will suffer with it sometime in their life. And many of these patients will suffer with it a lot and recurrently. So it is a big problem. And as I say, many of our patients will be bringing it into clinic. And so it's important to be on the lookout. So considering this is so infectious, as it would seem, with 25% of the world's population, if it's that infectious, why haven't we all got fungal foot infection of one sort or another, as tinea pedis or onychomycosis? Well, one of the main theories, or certainly more theory, there's more research gathering momentum for this theory, is genetics, in that it seems to be, as you can probably realize from what you see in patients, there are patients who get it recurrently and they get it time and time again, and there are other groups of patients who never get it at all. And this has led to the idea that there are obviously genetic factors. Now, it's quite possible there is a heritable gene, if you like, that it's been postulated affects one's immune system, particularly the part of the immune system that is responsible for fungal surveillance. And in a fair proportion of patients, this gene is not working, or it's basically, it's leading to this case where people are not able to treat their own fungal infections, they're not able to fight it with the immune system. And this possibly makes up a large subset of the population. And this would also explain why in families you may find that the father has it and the two children recurrently get athlete's foot or onychomycosis, but the mum or another family member who may be living in the house never get it at all. And it may be purely down to genetics. Other things have an effect as well. Climate. We know, for example, that fungus likes to thrive in moist, warm environments. So we see a higher rate of infection in the tropics. But also spare a thought in the cooler, more temperate parts of the world, where we are, for example, where is it often quite warm and moist in a shoe? So in populations where shoe wear and closed-in shoe wear for prolonged parts of the year. So you're talking about Northwest Europe, for example, these areas will have high rates of infection. Other things as well play a part. Fungal infections are more common in people who have contact with animals. And also in part, it's down to the virulence of the type of fungus that you're dealing with. Certain strains of fungus are more active, if you like, in evading the immune response, and consequently are more likely to spread. But on the whole, it's probably more related to genetics and also one's individual lifestyle. When we talk about onychomycosis, and this is a message I try and get across a lot, it all begins on the skin. Fungus doesn't just suddenly appear in the nail. It's a very impenetrable barrier for the fungus to invade without having, if you pardon the expression, a foothold on the skin first. And this is the key step, if you like, in the infection process. It all starts on the plantar surface. And it starts on the plantar surface as good old tinea pedis. And of all the dermatomycoses, or all the cases of dermatophytosis, if you like, this is the most common. And it's the most common. We see it much like we see on this patient here. We have a very dry looking foot. You see those white lines accentuating the sort of crisscross pattern of the natural skin creases. That's a very strong clue to fungal infection. Doesn't itch, doesn't give any symptoms. We don't see any blistering. And often there's a vague red background to it. And that may all be that is visible to the patient and to the podiatrist, but often it's disregarded, considered to be something like dry skin, for example, and treated with emollients. But patients can carry this for many years. In fact, it's quite probable many patients pick this infection up on the sole of their foot and it's there for many, many years. Often they pick it up in their 20s or 30s, and it will lie there dormant, and then it will spread eventually to other areas, particularly into the nails, causing onychomycosis, which is what we're talking about here. Now, what are the infection rates that we know of? What does the research tell us? We know it's a very, very common problem, but about 36% of adults in Europe have some form of fungal foot infection. They have onychomycosis, tinea pedis, or both. Now, as we move up the age ladder, as it were, 50% of the over 60s will have fungal foot infection. So a fair proportion of the patients coming into podiatry clinics, for example, will have this. It's very, very common. And fungal nail infection occurs in about 10% of our patients. So it's not always the case that if you have recurrent tinea pedis, you'll develop onychomycosis. There are other factors at play here, and certainly things like trauma and nails which are traumatized seem to be infected much more than nails which are not. And that seems to be a significant part of what determines whether someone goes on to have onychomycosis following tinea pedis. So going back to our foot here, we should be looking out for this very asymptomatic dry skin. Very, very common. It may just be on one foot, it may be on both feet, and certainly if it's on one foot, it's markedly obvious when you put the feet together that there's something going on. And where you get asymmetry like that, you should certainly consider infectious causes like fungus as the main culprit, as opposed to other skin conditions such as psoriasis and eczema, for example. Now, from the skin, it will spread from the plantar surface along the base of the toes and eventually onto the top of the toes, and then it will move into the nail, as you can see here. Onychomycosis really isn't a nail infection. I would prefer to call it an infection of the nail bed, because ultimately the dermatophytes don't move from the skin into the keratin of the nail. What they're doing is they're spreading across the soft tissue, they're spreading across the skin of the nail bed, and by virtue of their presence there, they are gradually eroding the underside of the nail, which produces that white, yellow, sort of brown that we see progressing towards the cuticle or the proximal nail fold, that are all the telltale signs of onychomycosis. And if you look at this patient here, you can see a number of things. Firstly, there's obviously a nail change here. It's quite possibly, very strongly going to be onychomycosis. But look around, look on the toe itself. You can see there's a lot of scale on the toe there, on the skin of the toe, which tells you that there is infection on the skin. That's where it's come from. The other thing is, why is it in that particular nail? Well, look at the surface of the nail, particularly on the medial side. You can see here we've got a lot of ridging. Now, ridging obviously implies quite often trauma. So this is a nail which has been traumatized. It's probably lifted slightly, which has facilitated the ingress of the fungus off of the skin. And eventually what will happen is the fungus will take over the whole of this nail. And in time, probably over many years, because it's quite a slow process, it will erode the nail until it eventually just becomes very, very friable. It just crumbles and collapses. And that's a sort of typical long-term outcome of onychomycosis. Now, the thing to remember with all of this, it is very, very common. Many patients have it on the skin and in the toenails, but this is a disease which is preventable and to a fair extent is also treatable too. So why are we seeing so many cases? Why are we still having this problem? If we have drugs this can treat, if we have drugs that can help prevent, if we've got measures that can help prevent infection, why is it happening? What it tends to indicate is either it's not being recognized by the patient and they're not seeking treatment, or it's not being recognized or acted upon by the podiatrist, or it's not being treated. And quite often, I think it's the latter, because there are very few symptoms related to it that patients are not motivated enough to treat, because it's not too much of an inconvenience. Unless, of course, there is a big cosmetic issue with the nails, and then I think at that point patients become much more motivated. But I think it's important to stress to the patients exactly what untreated infection can lead to. So, as I would say to podiatrists and anybody dealing with foot health, recognizing and treating fungal infections is really your business. It's so common. It's very easy to detect. It's treatable, and we're doing the patients a disservice if we're just ignoring it and letting it spread, and those complications of it spreading into the nails. And don't forget, it can spread to other areas of the body too, particularly from the feet. It can spread onto the hands and the groin. And many patients will have recurrent groin infections, which they're completely unaware are associated with their athlete's foot, or they may have it on their hands, very, very dry hands, for example, again, which they may not connect with having recurrent athlete's foot, for example. But this is where we come in as part of the education and treatment package, if you like. So going back to our patient here, if we can catch it at this stage, then we can do a lot more for the patient. If it hasn't reached the nails, we can treat this very effectively with topical creams. They do work, but it's just about getting that message across to the patient. It's something they need to be educated about and be able to recognize what infection looks like, to know when to treat it, but also to know what will happen if it's not treated. This is another slide, again, just a fungal fringe, as I call it, on the side of the heel, for example. You can see quite well delineated with a few areas of hyperkeratosis, very, very common. And also in between the toes, you can see here there's two things going on. There's maceration and there's also scaling. Now, scaling we associate more interstitially with fungus, but maceration a little bit more with bacteria. So in this case, you've probably got a mixed infection, although it's very likely if you treat the athlete's foot, then the bacterial infection will subside too, because it relies on the presence of fungus to make it more environment in which it can thrive. So basically, if you take out the fungus, the bacteria can't survive on its own. And that's very, very common with interstitial infections. They rely on each other. So taking one out of the equation will often treat the both. So when a patient comes in and I recognize that they have athlete's foot, onychomycosis, or both, I will always spend time with them to advise them that they have fungal skin or nail infection. I think that's important. And often patients are very taken aback. They're surprised. They don't even realize that they've had it, or they feel slightly indignant because why should they get it? Because they're very clean. They always wear nice shoes and they shower twice a day and wash and dry their feet. But of course, that isn't the reason. The reason is susceptibility. People, where they go barefoot, will pick up this infection, and it may be with them lifelong, and they may never know that they've had it, and so it's untreated. And I think it's important to stress to the patient that untreated infection can spread to the hands and the groin, which is often quite motivating for many patients. And I think also bear in mind, if you have patients who have compromised circulation or at-risk foot or diabetes, for example, that untreated dermatophyte infection is a major risk factor for lower limb cellulitis. Now, lower limb cellulitis is far more serious, if you like, and it can end up hospitalizing a patient, making them feel very unwell, and potentially lead to life-threatening complications. So if ever there was a good motivator required, then certainly the idea that by treating your athlete's foot and your fungal foot infection, you're going to reduce the risk of more serious complications. And for patients who've had lower limb cellulitis or get it recurrently, as we discovered in the study we published in 2009, many of them have this association with fungal foot infection. And by treating the fungus, they can actually reduce the recurrence rate of their cellulitis. It's very cheap, it's very easy, and it's just about educating the patient to recognize the infection and know when to treat it. Now, once we have a suspicion, we have a patient, we have an infection, we have a fungal infection on the skin, it's always important to diagnose fungal nail infection. It's slightly different on the skin, but I think with the nails you have to be more thorough, and I'll explain that. It's important to make a diagnosis when you have a nail infection, because if you're going to spend time and invest time and money, and the patient's time and money particularly, in treating it, make sure you get the correct diagnosis, because only about 50% of nail dystrophies are fungal. The other 50% are not. Consequently, what that means is that there is a risk of misdiagnosis, and I'll talk about that in a moment. But of course, we don't always regularly test for onychomycosis, and that's not not something that we talk about a lot. But often it's about time. It's often because the patient's coming in about a different problem, and they want to talk about the presenting problem they've come in with, rather than something that you found that they're probably not particularly that interested in. The other thing is that many of us think that we can rely on our own ability to sniff out fungus and say when it's present or not. And we're all pretty good, but we're not perfect. We do get it wrong. And as I said, I'll come back to that in a moment. And the cost of a test in private practice, for example, if you send off to a private mycology lab, it may cost you 60, 70, 80, over £100 to do a microscopy and culture. Alternatively, you can send them to the GP. And sending it via the GP obviously ties up a GP appointment. It takes more time, and it can take up to 4 weeks to get a result. So often, many samples may be lost or may be difficult to locate. The other problem with microscopy and culture is the high rate of false negatives. About 30% of nail samples which are sent off which contain fungus will come back as a negative result. And that is just the basis of the test itself. It relies on people being able to visualize under a microscope the presence of the fungus. And it's also down to the skill of the operator. If you have somebody who does it a lot, who's been doing it for many years, they're very good. But somebody who's relatively new obviously won't be as effective. And many cases come back as false negatives. So patients are told they don't have it when they do, which can be very frustrating, particularly if it's very obvious. But you need to make a proper diagnosis to ensure it is what you think it is. The other thing, of course, is to ensure your treatment is likely to work, because if it's a traumatic condition on the nail, of course, a million years of antifungal treatment is not likely to work. But also there's a question of ethics in that if you're offering your patients the highest standard of care, that's good. But ethically, it's important to make sure you test that nail to make sure the infection's there, so you're doing the right thing. This will help your reputation and business, but it also means you're conforming to the UK recommendations on the diagnosis of fungal nail infections. Guidelines that are available consistently talk about how we should always test any nails if we're considering treatment for those reasons. And there are various methods of diagnosis. We can have a look and try and make a diagnosis that way, or we can undertake fungal culture and microscopy. And as I talked about there earlier, the problem with that is it has about a 30% failure rate, and it takes a long time. If your patient or your practice is very affluent, you might want to send a nail sample to histology and request a periodic acid shift stain. Now, this is a stain which shows up fungus quite readily. The only problem is, again, it's quite expensive, about £100 to £150. Above that, you've got the PCR test. So we're all familiar with PCR tests, which we've had during the COVID-19 outbreak. A very rapid test, only takes 24 hours, but a PCR test diagnosing fungal nail disease, again, could be anywhere up to about £300. The other way of doing it is using immunochromatography or a lateral flow test, and many of you may be familiar with this. I'll talk about that in a moment, but the microscopy and culture is a standard laboratory test, and as I said, it's usually done via the GP because patients are not happy to pay the £100 to undertake the tests, and it's not that reliable. The dermatophyte test strip is a relatively new innovation. It's been around since about 2017, and this is a lateral flow test where you have a strip which is impregnated with specific antibodies which are sensitive to the presence of dermatophytes. So by taking a clipping in the nail, putting it into a disposable test tube with a few drops of water, just like a lateral flow test we do with COVID, except we use a nail sample, this then draws fluid across the antibody field, and 2 lines indicates a positive result. And it is very effective. It only takes 5 minutes. It can be done in the clinic, and this is something which can be charged for as part of the consultation fee. The other key point is it has a high reliability. What do I mean by that? Well, there have been now 3 or 4 publications looking at the lateral flow test, or the dermatophyte test strip. And in the largest study, it was compared against PCR, the gold standard test. Remember, the one that costs hundreds of pounds. What they found was that the test accuracy was shown to be about 97.2%, which is very high and almost perfectly concordant with PCR. So what we now have is a test which is very rapid, very effective, and it basically negates the need for sending off clippings, because we can do it in the clinic and get a result. If we get a result immediately, then we can start treating straight away. So we have a patient. We've seen something that looks like fungus in the nail. We've now diagnosed something that tells us it is dermatophytes in the nail. So what are we going to do? Well, we have to get to the root of the problem. And the root of the problem is where it all started, which is on the plantar surface. And on the plantar surface, we need to clear the infection. That is the source, if you like. That is the fungal reservoir. So my first step for any patient is to get them treating their skin. Treat this first, and then you stop the onward march into the nail. It's not going to reverse onychomycosis, but for many patients just with tinea pedis, if they're educated at this level, it can prevent onychomycosis from ever occurring. So what sort of things are we going to have available to us? There are lots of antifungal creams on the market, and some of them are available over the counter, what we call GSL, general sales lists. Some of them are available through the pharmacy, and some of them are prescription-only medicines. And in a forthcoming blog on my website, I'll be taking you through which are available under the GSL, which means anybody can supply them to patients. And then we have the pharmacy and the prescription-only medicines. The key point I would make here is that often if patients are going to the pharmacy to buy them, or buying them from a supplier, whether that's a podiatrist or whether it is a pharmacy, that usually buying as a generic, so as you can see on the left, there are 2 generic creams there, terbinafine hydrochloride cream and clotrimazole 1% cream. These are usually much cheaper than using branded products. On the right here, on the right, you can see miconazole nitrate cream. You can see Lamisil, which is also terbinafine hydrochloride, and Peverol, which is a 1% iconazole nitrate. Not widely available, but it is licensed in the UK and you may come across it. But all of those you'll find are more expensive for the patient to use than if they can buy them as a generic. A bit like buying a headache pill, either as a paracetamol or as a branded drug. Usually the branded drug is 2 or 3 times more expensive. So which you supply is up to you, but always think generic and think what is available to you. But all of these creams will work on dermatophyte infection of the feet. Patients should be educated about how to use them, how long for, and so on. And that's key. And we'll talk about that a bit more. And, oh, a new one's just popped onto the market there. No, it hasn't actually. That's Canesten, which is also available from pharmacies. So you can use a cream, and patients generally have to apply a cream, I would say, for up to 4 weeks, 4 to 6 weeks. If they've got a heavy infection or they've had it for many years, I would even go as far as say use it for 8 weeks to get them into the habit of using it. And that is quite a tricky situation for some patients to remember to do for a week, let alone to 4 to 6 to 8 weeks. There is an alternative, though. The alternative to daily application of terbinafine, for example, as a cream, would be to use something known as a film-forming solution. Now, there's only one film-forming solution in the tinea pedis market in the UK at the moment, and that's Lamisil Once, which is pictured here. There's no generic available. But the beauty of this is the patient can go away, they can wash their feet, wash and dry their feet thoroughly, and then they apply this gel. There's only 4 grams, so 2 grams of gel to each foot, and they rub it all over their foot below the ankle, and it forms an invisible film. And this film remains active on the skin for 28 days. And what it means is they only have to do it once. Hence, they call this Lamisil once. And Lamisil once is very effective. There is very good research to show it is equally effective as using, for example, terbinafine cream once daily for 4 weeks. The outcomes are exactly the same. And also, this is more easily available. This is on the general sales list, Lamisil once, so patients can buy this at many different outlets. It is a little bit more expensive than the cream, but if you add up what cream you may use in 4 weeks, I'm guessing actually it works out slightly cheaper, depending on how much they use, but there isn't much in it. But film forming solution, Lamisil once, is a good alternative, particularly if patients are not able to do it. Of course, this may be something you want to do in clinic for the patient and charge for the service. So rather than going with the tube of cream, you sell them a Lamisil once, you apply it with them there, and then the job is done. But also good for business. If they're going to use a cream, it's important to give them the right information. And one of the main problems is that patients are just go to the chemist, they'll get a cream and they barely read the instructions. But it is important they use it correctly and use the right amount. And antifungals should always be used after the skin's been washed first to remove any debris or anything that may be on the skin that will prevent it from penetrating. And I would say use for a minimum of 2 weeks. In fact, I say 4, 6, 8 weeks if there's heavy infection, but they should continue to use it even after symptoms have subsided. How much should they use? Well, on the right here, you'll see this is a little finger, and this is a squirt of the antifungal from the distal crease to the tip of the finger. That there is what we now know is called a fingertip unit. And a fingertip unit is enough to do 1 foot for one application. And that's roughly half a gram. If it's a 5mm nozzle, which most of them are, it's half a gram. So you know that that will treat 1 foot for 1 day. So if it's terbinafine, that's a day's application, terbinafine to 1 foot. So 2 fingertip units to do both feet. In total, that's 1 gram. So 15 gram of terbinafine will be enough to treat a patient for a month. And that's a very good way to sort of quantify it. And so the patient knows exactly how much they've got to use, and they won't be using too much or too little. And there's creams are very, very safe, very low risk of irritation. And a fingertip unit is a very easy way to teach the patients exactly how much they should be using. And once they've got rid of the infection, don't forget, you can use an antifungal as a preventative. And I think this is important. What you have to realize is for many patients that virtually all patients, fungus will always come back. And it comes back for the same reasons which they got it in the first place. They're likely to be susceptible to reinfection. And also they'll have fungal fomites, spores, and squames of skin around their house, in their socks, in their shoes. And so it's very likely that once the cream has stopped working or once the treatment stopped working on their skin, then they are going to have problems because they're just going to reinfect. And there's good evidence to show that antifungals can be used as a preventative as well as a curative. Now, if you're interested in reading more detail, the blog article, the URL to my website, foot.expert, but that's a shortcut, and that will take you to the article which explains in detail. But essentially, the easiest way to use it as a preventative is to suggest to the patient they use topical terbinafine applied to the skin for 1 full week in every 4. And trying to get them to do that can be quite tricky. Obviously, we all lead busy lives and forget. Of course, you could also say to the patient, well, let me supply you with a film forming solution, and the Lamisil once, for example, and get them to use that once a month or once every 6 weeks. And remember, they only have to apply it once. So that's another alternative strategy. But either way, if they're doing that, terbinafine remains in or on the skin for up to 4 weeks, hence it's still active, and it makes the risk of recurrence much, much lower for patients. And if they're not getting tinea pedis back, then it also reduces their risk of reinfecting any nails which may have been cleared or cured. Also, don't forget their footwear. And one of the things you can think about there are ways in which you can decontaminate shoes. Now, this is a tricky business. There's a lot of research been done looking at how do you decontaminate socks, how do you decontaminate shoes as well to prevent reinfection. It's quite tricky, particularly fungal spores. Now, T. rubrum, which is the most common infective agent in dermatophytosis, in fungal foot infection, does produce spores, and these spores can be quite resistant. But some of the suggestions I give to my patients, first of all, there is a terbinafine spray. It's known, there's only one available. It's Lamisil 80 spray, 1% terbinafine. Patients can use that on their skin, but they can also spray a bit into their shoes from time to time. That will have an effect on any active fungus which is living on the squames of skin which is sitting in the shoes. The other alternative, which is probably a bit more cost effective because you get much more for the money, is to use something like hypochlorous solution. And the main brand that we're familiar with there is Clinisept Plus. And Clinisept Plus Podiatry is active against dermatophytes. Spray it into the shoes until the shoes are damp, and then let it dry out overnight. It will also work for socks too. On my blog, there is an article about using a hypochlorous solution to eradicate dermatophytes from socks. To be honest, it's quite easy for patients to go out and buy new socks, but some of our patients are very attached to their socks, and they may feel that they wish to pop them in a small sealable freezer bag with some hypochlorous solution, and so the sock's damp, and leave it in there for 24 hours. And some of the lab studies that I undertook with a private lab indicated that 24 hours of a damp soak in hypochlorous solution will eradicate 99.99% of the dermatophytes. Then the patient takes them out of the bag and washes them as normal, and so then that they're able to then wear them, and they should be relatively fungal free. But that's probably the best advice. There are other devices on the market. There's more often not seeing UV light, these little devices you put in shoes, and other methods, but there's a lot of misinformation there. But generally speaking, just washing the socks isn't enough. I would recommend spraying with terbinafine solution or Clinisept Plus Podiatry, something like that, which will help to keep the fungal population down and prevent it from recurring. And remember, we can also sell that to the patient in the clinic. So what about nails? When it comes to nail treatment, skin we can get clear fairly easily with a little bit of pharmacological know-how and the right topical treatment. Then we need to look at the nails. And as we're all aware, there are two ways to treat the nail. You can treat it with an oral medication, or you can treat it with a topical medication. Now, first of all, to say that using an oral medication is not a failure. I know people often try to avoid this, but let's just talk through this, because there are some patients who really require oral treatments over topical treatments. And the two main drugs that are prescribed in the United Kingdom are oral terbinafine and itraconazole. And these two drugs together have been used for many, many years, and they offer the best cure rates of any treatment. So they're better than any topical treatment that you can carry out. And they offer the best cure rates for patients of around about 80% plus. When's the sort of time that you should be considering requesting an oral treatment? Well, certainly when there's widespread infection in multiple nails, which is in the proximal nail fold, which is in the matrix, when topical treatments have failed. And if there is quite heavy infection, then obviously your oral medications are going to be your key treatment here. But remember, they're only available from a prescriber, such as a GP or anybody who has an independent prescribing license. And for both of these drugs, there are blood tests required prior to starting treatment, because potentially they can have an effect on the liver, particularly any patient with pre-existing liver damage. So what a blood test will do is check the liver function and make sure the liver is working correctly. Because if these drugs are given to someone with poor liver function, who may not realize they have poor liver function, there is a very high chance that it will cause problems and significant side effects. So blood tests are usually carried out just before the treatment is commenced to ensure that liver function is okay. The other thing to do is to talk about with your patients exactly what oral treatment is and what it isn't, because sometimes it's seen as the panacea, the cure-all. And of course, all drugs have side effects, and patients should be advised of this. And oral drugs do work. They have about an 80% success rate. And the other thing to remember, and this is an important point, is they don't correct nail deformities or any prior damage to the infection setting in. So they can't make a 70-year-old's nails look like they were 12 years old again. They can only remove fungus from the nail. So they'll help with the discoloration, they'll help with many of the symptoms, but the nails may not look perfect afterwards. And that's important to point out to the patients. They will look a lot better, but they won't be perfect. Some would say that, only a small percentage actually look perfect after oral treatment. So do prepare the patients for that. Really, they shouldn't be taken for more than 3 months. And if you're going down that route, obviously they need to be referred back to their GP or whoever's prescribing it for a prescription. And obviously they'll need that blood test. Now, oral terbinafine tablets are the most common. They're the first line that are prescribed in the UK. They're taken for 12 weeks or 3 months, once a day, 250 milligrams. And they're very good against a broad range of dermatophytes. And the main reasons that people don't like them is that they cause stomach upset or taste disturbance. There have been question marks in the past about the safety of oral terbinafine. And so this is something that I've delved into, and I've produced a blog. There's the link below. How safe is oral terbinafine? You'll find it on my blog. And it's a detail of exactly how safe it is. And it gives some very good statistics there, suggesting that the risk of serious side effects is very low. But do have a read of that. The second drug on the list is oral itraconazole. And oral itraconazole is taken 200 milligrams once daily for 3 months. The other way it can be taken if patients are not wanting to take a vast amount of medications is as a pulse therapy. So a patient takes the tablets once a day for a week and then has 3 weeks off, and then does another week, tablet once a day, and then does that 4 times, 3 to 4 times. So basically they have what's known as itraconazole pulse. Itraconazole is, in terms of its effectiveness, is equally as effective as terbinafine. It's also very good against yeasts and non-dermatophyte molds, much better than terbinafine, but those are much less common. The downside of this particular drug is that it tends to react more with other medications the patients may be taking. So it tends to be used slightly less than the other medication terbinafine in the United Kingdom, but it is still useful where you have yeast infections. But as I say, yeast infections are much less common, more common on the hands, in fact, but quite rare on the feet. So it's not a commonly used drug unless going to use the pulsed therapy for patients who'd like to minimize their drug use for their treatment of their onychomycosis. There is some good news. There are new drugs in the final stage of development, both oral and topical agents. They go through their various testing stages. They have phase 1, 2, and 3 and a post-marketing survey. But if you're interested in knowing what's coming next, there are 2 links here. Probably the closest to being launched is the new 10% terbinafine topical solution, which I hope to see in the United Kingdom in the next 12 months or so, which in its clinical trials has performed extremely well, as it is a formulation which is absorbed very well into keratin, which is exactly what you want if you're treating fungal nail infection. And the terbinafine dosage in Z10%, that's 10 times higher than the 1% that we've got available at the moment. So one would hope it will be much more active. But do have a read at those 2 links if you want to find out more about those drugs. Okay, let's look at topical nail treatment now. So oral treatment is good for some patients, particularly with severe infection or patients who like the convenience of taking an oral medication. But then you'll find that there are a group of patients who, for whatever reason, whether it's because they're on many other medications or they don't like the idea of taking a drug which potentially can affect their liver function, albeit quite rare, they may rather have a topical nail treatment, something which is much safer. And also, this can be carried out in the clinic. In the UK, there is only one licensed medicine for the treatment of onychomycosis. And that drug is amorolfine. And it's amorolfine 5%. And it's available as a nail lacquer. And this is applied once a week. Now, this is available from pharmacies or on prescription, and it goes under two names, Losaril nail lacquer, and there is another one called Curinail, which patients can buy over the counter as well. The problem with this is that it's a lacquer that's applied onto the surface of the nail. So if the nail is very thick, it's not going to have much an effect because it's not readily absorbed. It just dries onto the surface of the nail. The second problem is that it can take a long time. Even on a thin nail, it can be a treatment time of over 12 months. And over 12 months, the patient can pay quite a bit of money on this product and see very few results. With a success rate below 40%, it's not entirely convincing for most. And I think when I speak to patients about this and tell them the rates, then they do have a good think. Of course, reducing the nails regularly with a drill, for many of my patients who'd rather take the amorolfine route, what I'll say to them is they'll get a much better outcome if they come in every 2 months and just have the nails very quickly reduced. What that means is the drug is more liable to penetrate much more deeply into the nail and a higher success rate, and several studies have shown that. So just getting the patient back for regular nail reduction while they're using this is certainly a way of increasing its effectiveness. But either way, it's going to be a long haul, and most patients it takes over 12 months, and only about 40% of patients are successful in completely eradicating it. There are another group of products which are not medicines. Some of them are just cosmetic or called medical devices that are available for home treatment. And you may be familiar with a lot of these, Mtrex, for example, Clearzal nail treatment, and a whole range of them. They're not medicines, so they work in a slightly different way, in a non-medical way. They have a variable range of effectiveness. Now, when you look at the number of products on the market, there are lots of them, and sometimes it's very hard to discern which are the best and which are the not so good. What I've done, again, there is a blog on the website called Home Treatments for Onychomycosis. Are they any good? The shortened link is down there if you want to have a read, but it covers all of the common home treatments that are the non-medical and the medical devices that patients can use. Some of them are available for podiatrists and foot health practitioners to sell to patients in their clinics, and it gives you some of the evidence. Mtrex, for example, has 2 or 3 papers showing its effectiveness in a number of studies. It's not obviously not as effective as oral terbinafine and other topicals, but it is showing promise in that respect. And there are other medical devices which are covered in that. So if you want a quick review of home treatments for onychomycosis, do have a read of that for more detail. The other recent development, I say recent, probably in the last 5 or 10 years, is nail fenestration, or basically making holes in nails. And it's not a new principle. It was first sort of considered way back in the 1980s. In those days, though, this was by American podiatrists, and they were making holes with very expensive bits of equipment called carbon dioxide lasers. And carbon dioxide lasers are in the wrong hands, are quite a lethal weapon. They can make holes in nails, but they can also do a lot of damage. But fortunately, things have moved on since then, and fenestration has taken a slightly different direction, not using lasers which cost tens of thousands of pounds. But there are devices such as the Clear a Nail device, which is able to make holes in a nail without damaging the patient. And Clear a Nail, as far as I'm aware, it's the only medical device registered for this purpose in the United Kingdom. And essentially what it will do is it will drill a hole in the nail. And as you can see here under the dermatoscope, you can see that the holes go right through the nail without drilling the nail bed. And what this means is that then if the patient is instructed to use a liquid antifungal, such as terbinafine solution, there's also Canesten solutions are available as well, not so easy to acquire. But either way, applying a solution to the nail means that it will go straight down the hole, and then it will be soaked up by the fungal hyphae or the fungal mass under the nail, and it's retained under the nail, and it will have its effect there. So it allows the nail to become much more porous and allows the drug to penetrate and be more effective. And on the basic principle, that should lead to a better outcome, of course, but we'll have a look at some evidence. How is it carried out? Well, remember, if you're going to treat the nails, always treat the skin as well. So the first thing I always do is make sure the patient is treating their tinea pedis and that's eradicated. And then I'll use the Clear a Nail device to all diseased areas of the nail. And I generally recommend the use of Lamisil 80 1% spray on the nails 2 to 3 times a week. They don't need to do it every day. And apply it to the nail when it's flat and leave on for 2 minutes and then rub in excess. And that will allow enough to get under the nail. And then I generally review the patient every 6 weeks. And as the condition improves, what you'll find is the nail color should change from that yellowy brown to more of a white as the fungus is cleared away and it dies off. And given time, that will grow through. But patients need to be monitored and seen every few weeks just to keep the good work up and to inspire them to continue. And just to show you one patient, and this was the result after a year. They only had the Clear a Nail treatment for a few months, and then they just had to wait for it to grow through. But it can be done. You see the skin condition is also much better in the right-hand slide because they're using their regular antifungal on their skin to prevent reinfection. This is another patient, and this actual presentation on onychomycosis is called nail spikes. Nail spikes, in fact, are one of the most difficult ones to treat. Even with oral medications, they can sometimes fail with a nail spike. That's basically a long strip of fungus that goes distal to proximal, as you can see on this patient. But few simple holes, and you can see the holes have gone right through there. And the patient didn't feel a thing. And again, send them away with some Lamisil 80 spray 1%, and they're spraying that on 2 or 3 times a week. And what this patient found, they said within a month or two, the fungal nail became very, very soft and it just fell away. The solution obviously killed off the fungus. And at 8 weeks, what had happened is all the fungally infected nail had fallen away and the new nail had grown through. What I suggested to the patient is they still use a cream on that for that purpose. The question, of course, is it's all very well me telling you that, but does boring holes in the nail make any difference? And just to say, yes, it does. There's been a very good research paper by Shenma, which shows a comparator between drilling holes and not drilling holes and topical and oral treatments. Patient compliance is very, very high, but it significantly improves the outcome when you bore holes into the nail, regardless of what treatment you offer. But topical agents work much better. Anyway, my time is up. I'd just like to say thank you for watching. And in conclusion, from this, I say, as you're now aware, or certainly aware before as well, fungal infections are very common. Onychomycosis is the sort of next stage on from tinea pedis. And so the key to all of this is treat the skin first, and you can prevent and in many cases improve outcomes in onychomycosis. And there are a range of approaches, both topical and systemic, but systemic agents still have the higher cure rate. Thank you for watching and enjoy the rest of your meeting. Thank you.